Welcome everybody to today's Methods Matters webinar, which will be about an hour in length. My name is Belinda Jampo, and joining me today to help me in the back end is my colleague Amber Huey. Our webinar today, as you can see on the screen, is entitled the Peers Model Network, and it will be presented by Stephanie Harvard, Amin Adibi, and Zhina Majdzade, along with a few others that the presenters will introduce. And our moderator today is David Whitehurst. So I would like to begin the webinar by acknowledging the ancestral, traditional, and unceded territory of the Musqueam, Tsleil-Waututh, and Squamish nations, from whose traditional lands the BC Support Unit operates in. Our Methods Matters series is a monthly webinar series, and it's presented by the BC Support Unit's methods clusters, and it showcases emerging research in patient-oriented research on methods. We also do have a hashtag today to keep this conversation going called the Methods Matters. So if you guys do have any thoughts and opinions on that, you are encouraged to use Twitter to share that using the hashtag as well. We encourage an attitude of continuous learning, approaching new ideas and diverse perspectives with openness and respect. So our aim here today is to center previously underprivileged voices in our Methods Matter series. So I think that's about it for me. I'm now going to stop sharing my screen and I'm going to pass it on over to David.
Thank you, Belinda. Hello, everybody. Welcome to today's webinar. My name is David Whitehurst. I'm an associate professor in the Faculty of Health Sciences at Simon Fraser University, and co-lead of the BC Support Unit Health Economics and Simulation Modelling Methods Cluster. I'm the moderator for today, so you'll see me again at the end of the presentation when we get to the Q&A session. For now, all I need to do is hand over to Dr. Stephanie Harvard. Stephanie is a Michael Smith Foundation for Health Research postdoctoral fellow in the Faculty of Pharmaceutical Sciences at UBC. So without further delay, Steph, over to you.
Hi, everybody. Thank you all for being here. I have to say that I find it nerve-wracking when I'm on a webinar and I can't see a lot of human faces. So that's a challenge for me. But before I share my slides, I want to try to overcome that challenge and foster a moment of connection between us all. And I think it would be nice to do that while we honor the land that we're on. So today, when I'm presenting on the unceded homelands of the Musqueam, Squamish, and Tsleil-Waututh nations. And after this is over, I'm going to go take a walk around the water, and I'm going to reflect on the relationship between the people and the land, and the respect and gratitude that I feel for that. And while we're talking today, I'm going to reflect on Indigenous knowledge and how we can show respect and gratitude for that throughout our work. And I hope that everybody else is going to have the chance to do something like that today too. So thanks again for being here, and I'm going to try to share my slides now. So this is the first nerve-wracking moment of these webinars. Okay, so as you all know, today's presentation is on the Peer Models Network. And the Peer Models Network is run by a team of us, and there are a number of us here today. Zhina Majd is here. Zhina curates our Twitter page. And Don Grant is here. Don is a patient partner with us. And Leah Grantham is here. Leah is a cultural safety facilitator. And unfortunately, patient partner Allison McLean couldn't be here today, but we'll try to bring some of Allison's insights into the conversation. And Amin is here. Amin is our team member who is a modeler and a health researcher. And so after I'm done my little part, we'll go around and Zhina will give a presentation, and then our team is going to bring up some questions and conversation. So basically, the Peer Models Network is a project that has a lot of different layers. And so my part of the presentation to start off today is going to focus on computer modeling and to give a little bit of initial context for that. But then after, as the conversation progresses, I think we'll get into some different layers. And hopefully by the end of today, we'll have given a good impression of sort of the big picture purpose that our team has. Okay, so basically, to give a bit of context, in healthcare, there's a lot of decisions being made every day, and they affect people at different levels. So one level that decisions affect people is at the individual level. So in the doctor and patient context, at that level of interaction, people are often making decisions like, what treatment or treatments should I use for a new health condition? And then there's this other layer of decision making that goes on, and that's more at the public level. So in our context, we have a publicly funded healthcare system, and British Columbia has to make decisions about what's going to be covered in that system, what's going to be made publicly available. So those decisions happen every day, and they happen at those two different levels. Now, more and more, these types of healthcare decisions are informed by scientific computer models. And these are a complex sort of representational tool that allow us to think about and reason through the different possible effects of different decisions that we might take. And the example that I've put on the screen is a little imaginary example of Dr. Bonnie Henry's desk, because in the pandemic, a lot of decisions have been informed by computer models, and that includes decisions around physical distancing policies. So that's an example that I think we all have some awareness of right now at the public level. So for me, the thing that interests me a lot is models are really complicated. They're hard to understand. They're hard to understand for me when I talk to my colleagues that build them. A lot of them include multiple sources of health data from lots of different places. And they perform complex functions like prediction. And sometimes they include a time component. And this level of complexity, it challenges us, because the thing is that we have to foster transparency and engagement in the face of this, all of this complexity nonetheless. Nothing changes. And in particular, when we look really deeply at computer models, something that we can tell is it's not just a scientific process. It's a process that involves us using our social and ethical values and making decisions about really what's good and bad and what we really want to pursue and avoid in society and in our relationships with each other. So from this, we can tell that engagement with patients and members of the public is important, because to make those decisions, modelers will need to know what matters to patients and what matters to the public. And that was a topic of a previous study, and Dawn and Allison both worked on that with us. And Amber, I sent you the links to the two articles that we developed in that project. And so if anybody wants to look more deeply into what we mean by that, the role of social and ethical values in modeling, those articles are helpful. Okay, so today's goals are to show you some of the resources that we've developed through this Peer Models Network project. And that includes some video resources that help us understand what computer models are and what their role is in helping inform healthcare decisions, talking about the difference between things like clinical prediction models that inform decisions at the doctor-patient level, and then health economic models that inform decisions at that public level. Then we want to introduce you to our project, which is a website called the Peer Models Network. So I'll go through that. And then we want to have a conversation about patient and public involvement in modeling and all of the different layers that that brings up for us. Okay, so this is the playlist today. There's just 3 short videos that I want to show that are going to total roughly 6 minutes. So I'm going to press escape here and go to YouTube. We have a YouTube set up now for the Peer Models Network. You can find it by looking for Peer Models Network. And the first one that I want to show is, this is the first video in a series about computer modeling and its role in informing healthcare decisions. So this is a playlist called Science and Social Values, Values in Modeling. So this is the number 1, and I'm just going to maximize here and go to the start and press play.
When it comes to public decisions, there are a few things you just don't hear people say. I hope it takes place behind closed doors.
Can we make sure that no one affected by the issue is involved?
I feel best when evidence is incomprehensible.
On the contrary, many agree. Public decisions should be transparent, informed by those affected, and based on evidence that people can sufficiently understand. This brings us to public decisions in healthcare. Decisions like, what treatments are available? What equipment is there in hospitals? And how many nurses, doctors, and other specialists are in the workforce? When all's going well, we might not think much of these decisions. But in a health emergency, that can change. How do healthcare decisions get made? In fact, many healthcare decisions are informed by scientific models, built by researchers like health economists. This makes it hard to be fully transparent with healthcare decisions, since not everyone's familiar with scientific models or research. For all we know, this octopus could be a health economist. Ideally, we want healthcare decisions to be transparent, understandable, and informed by the people they affect. So we're creating videos to explain relevant concepts, like scientific modeling, social values, and health economics. Keep watching and get in touch.
Okay, so that's the introduction to that big picture series. And all the folks on our team consulted on that. So now I'm going to move on to two other videos that talk about specific models. And before I do that, I want to acknowledge, I don't think we have anyone from that group here today, but I want to acknowledge the patients through the BC Lung Association that have given us input on these. And eventually, depending on their feedback, maybe these will come down and we'll make them better. But these are videos about models about a disease called COPD. So I'm going to start with the ACCEPT model, and this is a clinical prediction model.
Welcome. You're watching a video on the ACCEPT model. We have 90 seconds to explain what ACCEPT is. ACCEPT is a clinical prediction model about a lung disease called COPD, or chronic obstructive pulmonary disease. COPD is a chronic disease that impacts the breathing and a person's overall wellness. People with COPD experience exacerbations, or flare-ups, which means that symptoms worsen. Preventing these flare-ups is a major goal of COPD care. That's where ACCEPT comes in. This model uses clinical and demographic information to predict flare-ups, including their frequency and severity, for an individual patient. This information can help doctors and patients decide when to start using preventative treatment. Medications to prevent COPD flare-ups exist, but they have potential side effects, so the decision to use them should be made carefully. The ACCEPT model is evidence-based. It uses information from 3 different published clinical trials. Like all scientific models, the way ACCEPT is built reflects its purpose and priorities. Your feedback is welcome.
Okay, so now I'm going to move on to this video here, which is about a health economic model. So my purpose here is to contrast the different types of models.
Welcome. You're watching a video on the EPIC model. We have 2 minutes to explain what EPIC is. EPIC is a decision analytic model about a lung disease called COPD, or chronic obstructive pulmonary disease. COPD is a chronic disease that impacts the breathing and a person's overall wellness. It's one of the leading causes of death in Canada and a source of high hospital costs. For all these reasons, we need strategies to improve health and reduce costs from COPD. Some possibilities are programs to reduce smoking, detect undiagnosed COPD, or give treatment to prevent COPD flare-ups. But how can healthcare decision-makers choose which programs to fund? Healthcare systems have limited budgets, so the goal is to fund programs with the greatest effect for the lowest cost. That's where EPIC comes in. Its purpose is to analyze the costs and effects of different ways to reduce the impact of COPD. The model works by representing the population of Canadians. simulating how many people have COPD and how many will develop it over time, based on real demographic and risk information. It also simulates people's health, healthcare service use, and healthcare costs, all in the context of different health programs and what-if scenarios. This shows how healthcare funding decisions could influence the overall impact of COPD. The EPIC model is evidence-based. Its information comes from scientific studies and COPD experts. Like all scientific models, the way EPIC's built reflects its purpose and priorities. Your feedback is welcome.
Thanks, everybody. And acknowledgements to the animator, Lauren Da Silva, who did the animation in those 2 videos there. So now I want to go over to the Peer Models Network webpage, and I want to show you just a few functions that we've developed. So the purpose of our project is to just basically foster more awareness and understanding of the fact that computer models are being used to inform healthcare decisions, and also to build some knowledge around, what they are and how they work. And the reason for doing this for us is to promote engagement down the road, because being able to partner with patients and the public in modeling is going to require some legwork in terms of bringing this topic to the fore. So the few things that we're doing here, and I'll just show you a few features of the website today. So we do have a videos page, which also links to the YouTube channel that I showed you. But we also have a blog. So through this blog, our goal is to talk to folks about their own perspectives on modeling and to bring some of their knowledge out and explore the relationships that are relevant to this topic. So for example, the most recent blog post is an interview between me and a fellow called Nick Bansback, who has developed an app that goes along with models to help present the results and explain sort of how clinical prediction modeling works in practice between doctors and patients who are making decisions together. So that's that. And then we have a few other entries with modelers, for example, with Carolyn Colleen, who developed the physical distancing model. And for example, we have an interview with Allison, who I mentioned can't be with us today. But Allison is a really important member of our team, and she talks a lot about the importance of increasing representation for Black people in healthcare and responding to Black people's concerns. And so this interview with her is really important as well, in bringing up some of the different layers that I was talking about in terms of reasons for engagement and transparency in computer modeling. So I hope that everyone here will have a chance ultimately to check out our website and let us know, what you think of the blog posts. But in terms of the other functions of the website, we've tried to establish that, down the road we could have a forum. So there could be sort of a question and answer forum where people posed questions to modelers about specific projects, or general questions about how computer modeling works. In addition to that, we have a participate page, and what we're highlighting here is this idea of developing a panel. So this would be a panel of patients and members of the public who were open to the idea of collaborating down the road. So when modelers perhaps are working on a new project and they want feedback in their development phase, the idea would be that folks who are interested in this would be receiving an email list, and opportunities could be updated for them so that they can give feedback sort of as modelers are in their development phase. Now, in addition to that, we have a models repository. So this is a technical aspect that Amin is going to talk to later. But this actually allows for computer models themselves to be hosted on the cloud. So this is the really interesting part of the project. It's actually the backbone of the technical back end of this project. So that's our website. And I'm going to go back here. I just want to mention that we have a survey that's ongoing, and we would love if folks here wanted to check out the Peer Models Network page and then do our survey and let us know, what you think. because our goal really is to hear from you. And today I know a focus is on, methods and patient-oriented methods that, we're putting to use. And, for us, talking and listening to each other is a really big key component of that. So we would love to be able to hear from you. So I just want to thank the funders of this project. Of course, we're not over, and I'm going to send this over to Zhina now, but on my end, I still want to thank the funders for the Peer Models Network, which includes the BC Support Unit and Academic Health Science Network, as well as the Canadian Foundation for Innovation. And as well to thanks to everybody that's on our team. So Zhina, I'm going to send it over to you now. I'm going to press stop share.
So hi everyone, as Stephanie already introduced me, I'm Zhina, and I'm just gonna quickly share my slides. Okay, so I've been running the Peer Models Twitter page for almost a year now, and I just thought that I would spend today talking a little bit about my experience and what I've learned throughout this journey, as well as some sample tweets that we've talked about. So firstly, to begin with, the goal of our Twitter account is, of course, to promote our website, any blogs that we post on our website, and our YouTube channel. Our second goal is to post content that's related to scientific modeling, public health, and health economics. And our third goal, which is also the goal I want to mainly talk about today, is to raise awareness on the importance of having diversity in public and patient engagement. So a reoccurring issue that I've repeatedly encountered and that really caught my attention was the extent to which we are lacking diversity in modeling and science. Because health research is primarily dominated by white individuals, Black, Indigenous, and other people of color are often underrepresented. And so I thought that we could explore 3 angles with which we could tackle this issue. The first angle is social justice. So this viewpoint says that in order to have a fair and just health system, we need to make sure that racialized and minority groups are equally represented in research and modeling. To highlight this viewpoint, I tweeted about an article a couple months ago that highlighted that for years, Black people have reported receiving substandard care in hospitals. And the pandemic has only highlighted the impact that racism has on our healthcare and exacerbated this issue. Now, this is definitely not a just and fair health system. And if we wanted to follow the social justice perspective, then we would need to make sure that the systemic racism in the Canadian healthcare is not overlooked and that we actually address this issue. The second viewpoint I wanted to talk about today was transparency. Transparency means to make data sources and limitations explicit, and also requires that Black, Indigenous, and other minority groups play an active role in choosing data sources and identifying and addressing their limitations. So here I tweeted about an article which explicitly stated that the data collected from Indigenous communities regarding COVID-19 in Canada is insufficient. And this really shows how a lot of times minority groups are excluded from public health data collection. And so being transparent about this is great, because the first step to gaining public trust in modeling is to actually address all the inequalities that are present in the data. It is only after we address these limitations that we can move on to the next step, which is finding a solution for these problems. So it's really crucial that we remain open, honest, and transparent about the inequalities in our data and in our models. The third angle is good science. Good science is science that receives criticism from a diverse set of perspectives and then transforms in response to that criticism. So here I tweeted about a study which was analyzing the inequalities in cancer risks. And the study found that Black and Latinx residents were actually exposed to a higher risk of developing cancer due to social determinants of health. And so the irony here is that a lot of times these two groups are also the groups that are underrepresented in our research and in our models. So if we want to produce good science and develop models that are accurate and meaningful for all patients, then we need to make sure that all demographics are equally represented and that no group is left out. So as a concluding thought and really tying these three angles all together, although we are learning and still improving, we need to continue to work on strengthening our patient and public engagement and modeling, and to continue seeking to increase diversity in this field. Now, of course, I'm still learning myself as well, but this has just been my take on this issue, and I would just love to hear if anyone has different ideas or anything that they would like to share. But other than that, that's it from me today.
So am I back on? I'm not someone that knows how to use these webinars very well. So anyway, I think I'm back on, and I can now move on to asking some questions of our team that helps bring out our individual perspectives. So the first person that I would like to ask a question to is Leah. And actually today, Leah's gonna field two different questions. So I'm gonna start with Leah, in terms of engaging patients and the public in modeling, we've talked a lot about why this is a social justice issue. And Zhina just touched on that, but I would love for you to add your perspective if you would. I think Leah's here. I'm gonna maybe move on to Dawn. Dawn and I touched base not long ago, and we talked about the fact that our project is really big picture. And we talked about the concept of target audiences. And Dawn was telling me that he thought we needed to work on that. And so Dawn is here today. So let's bring up this topic again. Dawn, can you tell me your point of view in terms of identifying target audiences for us?
Yes, Stephanie, I will. I acknowledge that I'm talking to you today from the Silks Nation, which is home to the Okanagan peoples. And much as the grounding that Stephanie shared with us in terms of her walk along the beach later today, I'm going off for a walk in the woods later. So my thought is there's certainly great value in the Peers Model Network. And I just wonder if we can get even more value from the work we're doing by being more specific about who our target audience is. And to be even more specific here, I suggest maybe having, or at least exploring the value of having aimed at, say, some for politicians, for example, some for the public, some for researchers, some for the healthcare professionals. And like right now, the holistic approach is good, but I just think we potentially are missing some value by being too broad. I'll leave it at that, Stephanie.
Okay. I'm gonna respond to that and say that Dawn and I are in agreement on that. You know, I think that something that we can sometimes do in a project is try for too many goals and then fail to reach any of them because we're not really focusing enough on a strategy. And so I think that moving forward, like I would love to be able to talk more, especially to folks like yourselves who've chosen to come to our webinar, and talk about our priorities, because you know you have to start somewhere. And this year we've started with the big picture and started with the idea of raising awareness about all of the different layers and all of the different angles. But I think that for the next steps, we're going to have to get some insight from people about where to focus our efforts first. So maybe I'll put a pin in that for now, and that could be something that we raise in the question and answer period. But I know Amin is here, and so I just want to move over to talking a little bit about some of the technical aspects of this project, because that's actually a pretty exciting part about it. I don't know if everybody knows, but Amin is actually the developer of this technological infrastructure that allows for all of this to happen. So I'd love to get Amin's sort of point of view on the significance of that and the challenges, and any other sort of insights that you would have, Amin.
Sure, thank you, Stephanie. I'm joining you from the traditional and ancestral territory of the Musqueam Nation. One thing that we were, that was sort of was the initial reason that we went after this this project was that a lot of models that people develop are hard to access. in computer science, there has been this long tradition of open source movements where people are encouraged to publish the code of the software to develop, and that could include, models that are used in healthcare. But even when people do that, how often have you gone and downloaded someone's model's code and been able to run it yourself and scrutinize it? It's very difficult. It's very difficult because from a software perspective, it's hard to understand what others have done. It usually requires quite a bit of technical knowledge. And sometimes from a hardware perspective as well, the models that are more complex may not be accessible to a lot of folks because they may lack the hardware infrastructure to be able to run those models. So our idea was to be able to make the models more accessible by making them a lot easier to access. So what we have done on the technical side of the Peer Models Network is that we have built a cloud-based infrastructure that hosts models. These could be cost effectiveness models, this could be clinical prediction models, all sorts of healthcare models on a cloud platform. And people can have access to those models through a standard software APIs, which basically means that you can use any piece of software. It includes things like R, Excel, web apps, iOS and Android, smartphone apps, you name it, and be able to call the models, send your inputs, and get the results back. And the idea is that a lot of times you get more transparency by being able to interrogate a model. So I might not be able to go read thousands of lines of someone else's code and find a mistake there, but I may be able to give an input and see if the output makes sense, right? So if we get predictions that are way off, obviously, if I come up with a COVID model that predicts 1 million deaths from today till next month in Canada, then there's obviously something wrong with it, right? So we've built an infrastructure that basically enables direct access and interrogation of models by all sorts of stakeholders. And we have built tools around it. We have web apps, we have Excel sheets that are very easy to work with. So whether you are another modeler, a physician, a policymaker, a journalist, a patient advocacy group, we're making tools for you to be able to scrutinize these models. And that way, we are basically making these folks more powerful, because now that you can scrutinize the model, now you have the power to question the model as well. And that I think fits nicely with other aspects of the Peer Models Network that encourage active participation of all sorts of people who have a foot in the game in this whole business of making models and using them to inform healthcare decision making. So our idea is to be able to empower all sorts of stakeholders to be able to scrutinize the models and raise their voice and have their voices heard, hopefully.
Awesome. Thank you, Amin. If I talk, am I back on screen? So yeah, I mean, Amin and I are on the same page here in terms of, we both believe that, everybody can contribute in terms of assessing models, scrutinizing their adequacy for purpose. This might just happen at different levels. So probably not everybody's going to scrutinize model code. I can tell you I'm not going to do that. I had to do that during my PhD, and as soon as that was over, I was like, never again. But that doesn't mean that I don't want to scrutinize models at a different angle. And in fact, that actually is my main interest. It's my main scholarly interest, is scrutinizing the different things that go into models. And the level that I scrutinize models at, I think patients and the public can directly be involved in that sort of thing too. So that's something that I'd love to talk about more. I noticed that Leah is back. And so Leah, I'm gonna create a hybrid of the two questions that we had for you. So number one, we wanted your insights about why patient and public engagement in modeling is a social justice issue. And also from an Indigenous perspective, you and I have talked about, you think that there are barriers to engaging Indigenous people specifically in modeling, but also in healthcare decision-making. So can I ask you for your thoughts on that?
For sure. I'm going to split it into kind of a history versus present day situation. And I'm sure that my audience is really educated in Canadian history, so this is just going to be a brief overview, but you have the history of healthcare decision-making, and just like all legal decision-making being in Canada being made on behalf of Indigenous people and other marginalized people rather than in conversations with them. And some of the ideas that are coming to my mind are like the Indian Act, of course, and the provisions around healthcare, which are both extremely paternalistic, but are extremely significant for modern day Indigenous nations, because in the case of some, like the Treaty 6 treaty making with the medicine chest clause, it's allowing First Nations today to push back against paternalistic healthcare choices by saying the original agreements need to be honored, particularly around vaccination timetables. And then there's things like the Sexual Sterilization Act of Alberta, which was also done in BC, the history of Indian hospitals and sanatoria, and of course, the history of sterilizations of Indigenous women and Indigenous men were also sterilized historically in institutions, residential schools. So when we look at the landscape of Indigenous healthcare in Canada, it's very much been I know what's best for you, and I see you as a lesser human being, and this is how I'm going to control your life to create my ideal society. And that's true for many groups. That's true for mentally ill people, physically disabled people, like immigrants. It's all connected. It's all, there are unique provisions related to settler colonialism, but I see these issues as deeply, intimately connected. And then we just fast forward and we go to the modern day. The impacts are in education, because of course, until very recently, you had to surrender your Indian status to get an education at the university level. So the legacy of these inequities in education, in the ability to advocate for yourself in your healthcare by having this knowledge, we are still dealing with that. We are still dealing with Indigenous people who are terrified and traumatized from their experiences with healthcare providers. I have my own stories, even though I have a healthcare background in my education, even though I'm white passing, it still hasn't protected me in all scenarios. So we look at this is what we are dealing with. And I think that the ways that we have to address this is we start out by seeking Indigenous people and compensating them very fairly, both for their knowledge as Indigenous people and for the professional experience they bring. And once you kind of bring in the first level of Indigenous experts to consult with you on your projects, and you say, these are the gaps that we are seeing, they can provide that kind of feedback on the gaps that they see. And this is something that I've really enjoyed working with on Stephanie. And it just kind of helps the breakdowns begin. So one Indigenous expert turns into an Indigenous expert who brings in people from their community. Another Indigenous expert brings in people from their nation. Another Indigenous expert has connections with people in the First Nations Health Authority or tells other people about this opportunity. I'm making it sound like a pyramid scheme. I hope that's not what, but so that's our job right now as people who work in this professional sphere of healthcare, is just you need to find those experts, and you need to say very directly upfront, I'm aware of this history, I'm aware of these experiences and these perspectives, and I want to make sure that we are addressing these barriers and making space for you to be compensated fairly, for you to bring your perspective. And I know Stephanie's familiar with this, but there's a concept in Indigenous methods that's called two-eyed seeing. So you're looking at it through Indigenous eyes and through professional or settler world eyes, just kind of merging those. And I think that the more people that are brought in, the more opportunities for collaboration that exist, and the more recognition there is that Indigenous worldviews can constitute their own form of expertise, the more that we break down these barriers, and the more that we bring about a just and fair world. And, this is something that I want to speak to just from my own experience. People tend to have, even people who should or could know better, have a kind of myopic idea of what constitutes an Indigenous person. But there are Indigenous people with disabilities. There are Black Indigenous people. There are Indigenous people who have one parent who was an immigrant. Like, recognizing that diversity and trying to specifically expand your definition and your perception of who an Indigenous expert is will really make that big difference. And Did I cover everything? Is there anything else that I could talk about or speak to? Stephanie?
I think maybe we can open it up to questions.
Yeah,
now.
questions.
We have 2 minutes left, and I think probably a lot of folks will have questions for you, Leah, as well as maybe for other members of the team.
For sure.
David, do you want to go ahead and open it up?
Yeah, thank you very much, Stephanie and team. That was fascinating, sort of laudable objectives and huge potential for this project, which brings its own challenges, I assume. So we'll open this up for the Q&A. If you can enter your questions into the box, I'm going to be moderating this final part of the webinar from the traditional Coast Salish lands, including the Tsleil-Waututh, Coquitlam, Squamish, and Musqueam nations. So I will leave it open to you. We have a first question. So this is a question from Mosum. It says, a lot of what you mentioned about public engagement in decision-making is applicable not just to modelling. Can you, for example, comment on the recent controversy around not sharing COVID data by BC? Shall we take this conversation out of modelling and to the general health research landscape?
Maybe I think, can I answer that in a micro way and then toss it over to Leah? Because the first thing that I would say is, like, when we study what modeling is, it's a big range, right? And I think sometimes health economists or, particular types of scientists think of modeling just as simulation modeling, which are these models that have a time component, right? But modeling is kind of what science turns on. It's a big backbone of science. So I don't think of it, I think of it as sort of, an expression of science. So Mosen's question, which I appreciate a lot, it's like in the big picture, these issues are obviously relevant to science as a general practice. And I think I just would agree with that. So then I would bounce that to Leah and say, even if we don't necessarily use the word models, we just use the word science. Can you maybe give your input on Mosen's question?
Yes, I can. And I'm thinking back to this because a lot of BC First Nations have had a very tempestuous time getting any sort of honest answers from this government when it comes to COVID numbers. And again, that was an issue of a nation to nation relationship not being respected. And it kind of snowballed between I know that in this case, Henry and her team were valuing privacy, and the First Nations Health Authority and the other nations that were working on this, they valued accountability. And this is kind of an example of where the twain did not meet. And the consequences for this were disastrous, not just from a PR perspective, but I don't know if you're familiar with the situation in Cowichan. It also led to racist outcomes because when the COVID outbreak happened in the Cowichan Valley near Duncan, the local Cowichan nations volunteered to share that data, and they wanted to do so to protect their community members and to protect the citizens of Duncan. But what ended up happening is because there was those disparities between what data was being shared, it made it look like most of the people in the Cowichan Valley who were getting sick with COVID or were spreading it were Cowichan Nation band members, which led to racist violence. It led to attacks on Cowichan Nation members who were shopping in the city of Duncan or going down to Victoria to get supplies. But I guess what I'm trying to say is these decisions that are made, they have real world consequences that crash right up against the social problems that we have of racism, colonialism. And I really wish that teams would consider that. And you can't always see these things coming, but when they do, they stare you right in the face. Does that answer your question?
That's great. Thank you, Leah. We have a second question, which speaks to some of the comments from Don during the presentation about specifying groups. So Linnea asks, are there specific groups of people who you're most looking to engage with? And how are you intentionally trying to reach out to these groups, if so?
Okay, so again, I'm going to start with a little micro answer, and then I think I'll probably ask Zhina to give input. So we do have specific groups of people that we want to engage most with. We want expressly to engage with Indigenous people and with Black people, specifically, working with Allison. Allison advocates for more representation of Black people in healthcare decision-making and in modeling. And so those are two groups that, we're very interested in. But of course, we understand the diversity within those groups and, the importance of other folks, like Zhina said, we're talking about, many people having experiences of oppressive structures in society, including white supremacy and colonialism. So, a couple of strategies that we've been using are, we work closely with the HESM Methods Cluster, and we're doing community events where the folks being invited to give their perspectives are Indigenous stakeholders and Black stakeholders and community members. And in addition to that, for example, when we developed our video series, we invited people to contribute to that video series. Leah was one of the consultants. So we had folks from, for lack of a better term, target audiences, although that term for me falls down a little bit here because it seems one directional, and that's not how I think about it. But we had folks contributing and evaluating resources so that, we can make connections through developing our resources. And then in the interest of time, Zhina, I'll just, throw it over to you because you tweet in a way that amplifies the voices of people that we want to be in relationships with. So maybe you want to give your point of view there.
Yeah, I totally agree. I think that Twitter really helps with this because it creates this platform where you can engage with people from all sorts of backgrounds and demographics. And so we try really to create that balance where we are engaging with people who are from Indigenous communities and from Black communities and other racialized and marginalized groups. And I think that's a good way to sort of ensure that we have that diversity in our project.
Awesome. Thanks so much, Zhina.
Great, thank you. So we have a question from Sterling, and this is a question that I know Stephanie has given a lot of thought to, and a number of us have. So this is about receptivity. So how receptive have the modeling community been to the project and to the steer to try and incorporate different perspectives into the work?
Okay, I'm gonna field that and then bounce it to Amin. So I would say that what we've experienced this year, because we've been doing this for just over a year, right, is we've made the most ties with the modelers that we work really closely with. So Amin, for example, is a modeler on our team, and Amin and I talk about these issues a lot. And I would say that like Amin and our group of modelers is really receptive to these ideas. And in fact, like something that I really appreciated the other day was like Amin developed a model and then I did an analysis of it. And then we had a lab meeting where I analyzed it from the point of view that I take, which is a social and ethical view. And then we talked about it with our group. So we've had great reception with the folks that we've been able to have the time to really explore these issues in depth. I think a limitation that we have is those kinds of connections take a lot of time. And we haven't been able to make really deep connections like that with a lot of other modelers outside of our group. So when Dawn talks about things like target audiences and where are the priorities, that's something that we need to figure out, because if one of the things that we really want to make headway with is understanding these issues in conversation with modelers, then we need to foster that. We need to actually tailor resources to be like, hey, modelers, let's hang out and talk from this angle. So Amin, maybe you have some insights on that too.
Sure. So I think one of the challenges from both modelers and the members of the public is to raise awareness to this whole notion that this is a conversation that A, can, and B, probably should be happening. This is not something that modelers have been historically used to doing a lot of. And one thing that I'm finding more and more interesting is that the pandemic has helped. There has been a lot of awareness because of the pandemic, because the presentation that say Dr. Henry does every month on modeling for COVID in BC. There's been a lot of conversation going in the community, and one of the maybe few silver linings of this past year was that now it's a lot easier to talk to both modelers and members of the public about the importance of these dialogues when it comes to modeling. Another challenge that we've had is that for the most part, we've been focused on models that have been developed and have been out there for quite some time. And one of the practical challenges when it comes to giving feedback on those models and implementing feedbacks on those models is that a lot of folks who develop those models do not have funding anymore for those projects. So it's difficult for them to invest time and energy on incorporating feedback from the public. So I think we need to be thinking more proactively and more prospectively, so that we can have these conversations a lot earlier on. One of the things that our platform makes possible is for folks to be able to host their models as they're developing it on the cloud and try to get feedback from people. You know, you can send links to your colleagues, to members of the public, to all sorts of stakeholders as you're developing the model, have them look at it, have them provide feedback, kind of like how preprint servers work for our papers and publications. You know, sometimes you just put a preliminary version of your manuscript online and ask people to provide feedback on it, and you change it, and all sorts of versions will be available online as well, and it will all be public, which is very nice, because then people not only see the final product, but they see the evolution of your work. And I think this is something that probably needs to be happening with modeling as well, ideally. Mohsen talked about the recent controversy about data sharing in BC. And I was thinking, if the BC model for projecting COVID case counts was available online and we could all interact with it, I appreciate there could have been some challenges in communications, but it would also be a lot more valuable, not just because people could see for themselves what the policymaker is seeing and try to get some feedback about different paths that this could lead to, but because people will be more engaged in the whole process. And sort of, I feel like whenever I'm able to poke around and see how something works, then I'm more invested in providing feedback as well, right? Especially when it comes to things like COVID, which affects all of us in all sorts of different ways. The other day, Stephanie and I were in a patient group meeting, and I was very interested to learn from some of our patient partners that a lot of them have been following modeling presentations in BC closely and even adjusting their day-to-day routines based on the different projections of the model. So I think there's been a lot of challenges in this aspect, but we also have some unprecedented opportunity due to COVID. And if we can sort of harness that before it all dies down, then I think it would be very nice. It would be very nice to be able to use this momentum that is already out there to get these conversations going with all sorts of modelers.
Don, did you want to add something to that?
Thanks, David. No, Amin addressed it, just following me raising that hand. Thank you.
Okay, thank you. Maybe one very quick question to wrap up, and it's somewhat related. I wondered, Steph, if you could say something about, like, what are the major differences between trying to create material for a cold audience, something that not content experts, nothing about the topic, compared with people who already have an interest and some knowledge about an area?
Yeah, I think I would just characterize that difference, at least for now, for right now's purpose. I would say the big difference is that the chance of success is so much lower with the first one and higher with the second one. You know, it's so hard to create a video that somebody wants to watch if you have no clear idea in your head why they would want to watch it. So I think that really goes to what Amin is saying and to what Don is saying. I think that down the road, I'd love to get to the point where it's like, these videos are not made after the model is done. They're made while the model is being developed, and we're doing webinars like we have done with the BC Lung Association, but we're doing it in the process, and we're saying, okay, we're in the middle of doing this. This is how we're thinking about it. This is how we're thinking about the purpose of the model and the decision that it would inform. So what are we missing, if anything? What's on your radar that's not on our radar? And if there's mistakes to be made here, which ones are the bad ones to make that we want to be sure to avoid? And which are the ones that, okay, well, we can live with that if we don't do that? Those questions, if I was given the task of developing a video to then show folks on a webinar, I could do that. If I have kind of no idea what I'm meant to be saying or what the hook is, that's harder.
That's great. Thank you, Stephanie. I'll hand back over to Belinda at this point.
Thank you so much to our presenters for presenting to us today, and thank you all for joining us today. We also just want to reiterate that we do have the hashtag, if you want to keep this conversation going, called Methods Matters. And if you want to learn more about the methods clusters, you can visit our website, the BC Support Unit/methods clusters for that. And if you want more information about the Peers Model Network from this presentation, please visit their website at the Peers Model Network. So I think that's it for us. We would like to thank you guys yet again for joining us.
We would love if people would visit the Peer Models Network website, peermodelsnetwork.com, and then visit this link to do the evaluation survey, because this is how we're going to get info, what you like, what you don't like, and how we can move this website forward. Thank you so much, everybody.